Well, hello, everybody. This is anesthesia for the patient with respiratory disease today. I know you had a somewhat similar lecture about a week or two ago with Eric Nelson. We overlap a little bit, and I hope not too much. The one thing that has been kind of obvious literature-wise is that postoperative pulmonary complications are increased in this patient population. It's one of the main things we're concerned about. Especially pre-existing pulmonary disease is number one indicator for postoperative pulmonary complications. Not really surprising, but it has been shown over and over again. The other risk factors for those complications post-op are either thoracic or upper abdominal surgery are more likely to have problems afterwards. Smoking, history of smoking, also not too surprising. Obesity, age over 60, and then prolonged general anesthesia over 3 hours. These are all kind of established risk factors for pulmonary stuff in the PACU. Number one prevalent in the population is obstructive pulmonary disease. It's by far the most common encountered in our practice, and is comprised of various undergroups. Asthma, who has variable obstruction to the airways, COPD, which is fixed obstruction, and that can also be either chronic bronchitis as kind of a subtype or emphysema. The hallmark of obstructive pulmonary disease is increased lung volumes, so larger functional residual capacity and gas trapping, resistance to expiratory flow, that's the main problem in these patients, minimal elastic recoil, so they often use active expiration effort, use of their ventilatory muscle to expire, and they need to do slow, deep breaths if they want to be more efficient with their ventilation. The flow volume curves are tested again and again. It's a favorite, so that's something to actually look at. The spirometry curves for obstructive pulmonary. Can I show anything with the mouse? Oh yeah. For obstructive pulmonary disease, which you see here, this curve deviated to this side from the normal. This is the normal in the middle here. But this shows decreased FEV1, decreased FEV 25 to 75, and decreased FEV1 over FVC, and I think that's the most significant. Overall, an increased residual volume and an increased functional residual capacity. So on the lung volume scale here, which is rising to the left here, obstructive pulmonary disease has higher lung volumes, and then clearly an obstruction to expiratory flow here. Asthma is very common as a subtype of the obstructive diseases. 5% of adults are diagnosed with asthma and 10% in children these days, and that number is rising. Triad of clinical symptoms, coughing, dyspnea, and wheezing. And the underlying processes are chronic bronchiolar inflammation, airway hyperreactivity, reversible expiratory airflow obstruction in asthma, bronchial smooth muscle constriction, and microvascular edema and increased secretions. All those play together to create this obstructive pattern. The pathophysiology of asthma is the degranulation of bronchial mast cells. It could be allergic, IgE-mediated release of histamine, bradykinin, and leukotrienes and prostaglandins, or B, it could be parasympathetically induced with vagal efferents, which are also very sensitive to cold air and airway instrumentation. That's what we do all the time. The most likely time, it's a diurnal rhythm, it's around 6 a.m. That's when naturally intracellular GMP increases. So right when we start our cases, around 6, 7 or so, the first case is still when the reactive airway is probably at its most reactive. COPD, on the other hand, most common pulmonary disorder overall in adults, strongly associated with smoking and age. There's a male predominance, maybe due to smoking being more predominant in males as well, but that's not quite clear. Traditional classification includes A, chronic bronchitis, or B, emphysema, and most patients have features of both, so one doesn't exclude the other. The problem in COPD is that there's now fixed expiratory airflow obstruction and not variable anymore. This is a typical chest X-ray with signs of hyperinflation of a COPD patient. There are emphysematous changes. You can see on the CT here these nice emphysematous bullae that are showing up everywhere, and the overall lung tissue is quite destructed already. And this could be a typical patient. He's already wearing oxygen at home and has a bunch of smoking in his history. The problem of chronic hypoxemia in this patient is that they develop erythrocytosis. So the hematocrit goes up over time. They can develop pulmonary hypertension as a late stage because it's just getting so hard. The vasculature in the lung is affected as well. And then eventually the right ventricle will have a hard time pumping through this elevated pulmonary hypertensive vascular bed that they can get to ventricular failure that way, and that's called cor pulmonale. It's kind of the end stage of COPD and cardiac complication from that. The patients gradually develop chronic CO2 retention. The normal ventilatory drive becomes less sensitive to arterial CO2 tension and may be depressed by oxygen administration. And therefore, oxygen therapy can potentially precipitate respiratory failure. That's something we need to be aware of, at least. If they're hypoxemic, by all means, give oxygen, but just kind of be aware that this is an active medication for these patients. The preoperative assessment should therefore kind of focus on any symptoms of dyspnea on a daily basis. Is there any wheezing that you hear right now? Are they actively using accessory muscles to expire? Have they had recent fevers or pulmonary infections, which could make this a not so good time to do this surgery if they are having a pneumonia on top of things right now, which is very common all the time. Often these patients are on chronic antibiotics. And labs, possibly CBC would make sense, since you could estimate erythrocytosis and rises in hematocrit that way. And an ABG, you can always draw an ABG if you're not so certain how this patient is doing in the preoperative area too. Hypoxemia, defined in this patient population as a PaO2 under 60. Hypocarbia, if the PaCO2 is over 50, just be aware that this is severe COPD. Maybe a chest X-ray will be helpful if you have questions. We don't routinely get one, I don't think, but if you have concerns, it may be worthwhile getting one. And then this is the question, is there elective or emergent surgery today? If it's emergent, you go ahead, obviously. But elective cases sometimes benefit from further optimization before they go to the OR. Are they optimized? Yes, no. That's the big question, because these patients are not good baseline. So the question is, are they at their best at that moment? There is often some sort of preoperative PFTs, pulmonary function tests, are done in these patients if they have routine follow-up and see a physician. They usually get those relatively regularly. Pulmonary function testing per se is not useful in predicting perioperative risk. There's quite a few studies on that one. But so routine pre-op PFTs are only for surgical indication at this time recommended. So planning of lung resection and so on. But they can make sense in a kind of a chronic follow-up sense. And if the patients have those done, then it's worthwhile looking at them. We in pre-op clinic don't routinely order PFTs anymore like we used to for all COPDers. The smoking cessation question is a huge one. No more smoking, it says here. Remember, you have surgery in 2 weeks. I always thought, what is it useful for? You have someone who's so dependent on nicotine, and then they get off a substance they have been on for so long. Would it even make sense for so short before surgery? But it turns out that the sputum clearance is normalized after about 8 weeks of smoking cessation, and you have improved mucociliary function at 2 to 4 weeks after. That's not bad. if they can do that. So it's still advisable to tell patients to stop smoking. You normalize your actual carboxyhemoglobin content in your blood after 24 hours of smoking. So it's still worthwhile, even if they get into the hospital today, to stop smoking until then, maybe surgery next day. The carboxyhemoglobin related shift of the oxyhemoglobin dissociation curve to the right would then be shifting to a more normal level and increase the oxygen availability in blood. So it does make sense to advise patients to stop smoking, even in pre-op clinic shortly before surgery. Perioperative management. Question is supplemental oxygen. Are we hurting or improving? Subject of controversy due to possible suppression of the hypoxic drive, as we talked about. There was a study in 2002 in COPD patients randomized to PaO2s of 50 versus 70. There was no difference in pH, PaCO2, or need for mechanical ventilation. So it seems that a PaO2 of 50 is somewhat sufficient postoperatively for these patients. It's probably prudent and safe to provide sufficient oxygen supplementation, though, to achieve a saturation of at least 90%. You all know that a peripheral sat of 90% is equivalent to about what PaO2? 60? Yeah. So if you see 90, 91, you're probably good. If it goes in the 80s, I would probably increase the oxygen a little bit. But no need for these patients to have 100% SATs. They never have those. So you can probably kind of find a good amount for them when your goal is about 90 peripheral SAT. Beta-2 agonists or albuterol, mainstay of treatment for many of these. These agents activate intracellular adenylyl cyclase. They increase the CAMP and cause bronchiolar smooth muscle relaxation. They act very fast. We use them relatively routinely in the operating room because of their fast effect. In high doses, though, you get some beta 1 tachycardia, something to watch out for in especially cardiacally challenged patients. You can cause some cardiac arrhythmias with that. I see that a lot in children as well, but tachycardia in children is usually not a big deal. They tolerate that just fine, but in older people it can be a problem. And significant amount is lost in the ventilator tubing and the endotracheal tube, so if you administer it, make sure you give enough of it. It's always worthwhile to consider a preoperative JED-neb or ask the patient to use their inhaler right before induction. Corticosteroids, most likely used are hydrocortisone or methylprednisolone. These are the two agents we have available. They act anti-inflammatory, they are membrane stabilizing, and they have a somewhat delayed effect, though. So they are more for prevention of recurrence of airway obstruction rather than the acute treatment. But if you have a bronchospasm, it's worthwhile to treat with albuterol and then think about these to prevent any further, especially if you're still intra-op and you have a long post-op course to go. You can consider a 3-day course of steroids pre-op. In severe COPDers, if you're in pre-op clinic and you see someone you're really concerned about, that has shown to work really well for these patients. Like a 3-day pulse therapy before they go to the operating room of steroids. Should you stress dose them? Depends. If they're on chronic IV or chronic steroids, PO may be needed, but probably not necessary for the inhaled steroids that deliver just a very small amount of steroid into the airway. For those patients, stress dosing is usually not necessary. Now, what intraoperative technique to use? It's probably not quite decided if there's any one better than the other. If you do a general technique, and you may have to for many of surgeries, you have airway control, which is always reassuring, but you also instrument the airway. And you have stimulation during possibly light periods of anesthesia, right, during induction or emergence. And you may use drugs with histamine release, and those are probably not the best ones to use. Etracurium we don't have anymore, but that used to be a big kicker. But morphine is to be remembered, has a good amount of histamine release, and meperidine as well. So maybe those two are not the best to use. What is the best induction drug? Also questionable. Propofol It suppresses the airway reflexes. It has a bronchodilatory effect, the mechanism of which is unknown, but the hemodynamics must be stable for that one. Thiopental, it does not cause bronchoconstriction itself, but it's not as effective as propofol in suppressing airway reflexes. And ketamine is a direct bronchodilator, which is nice, but it increases secretions quite a bit, which can be problematic in these patients. So all of these have advantages versus disadvantages, and it just depends on the situation and your comfort. Regional technique avoids airway instrumentation, very nice. Pain controls, great. Early ambulation, all these things that we advocate when using regional, but you don't always have immediate airway access during a case. Should you have problems with the airway or the ventilation, the patient's own ventilation. Neuraxial blocks do block sympathetic tone to the lower airways if they go a little bit high. So T1 to T2 unopposed parasympathetic tone can be a problem. So peripheral nerve blocks can also block the respiratory accessory muscles that these patients depend on. Something to be aware of if you use regional technique. What about intraoperative bronchospasm? We encounter those quite often, I would think. They're usually cholinergically mediated. The cholinergic receptor, the acetylcholine receptor, is responsible for that. Triggers are airway instrumentation, could be an anaphylactoid reaction to anything we give. Inadequate anesthetic depth is a big one. I think that happens actually more often than we want to. Emotional stress. And drugs. Have we given any NSAIDs? Had the patient taken aspirin shortly before? Beta blockers or neostigmine can also cause cholinergic activation. So that's something to be aware of. Beta blockers, very careful in asthmatics. And when we reverse with neostigmine, it's often a time we see bronchospasm to that as well. Treatment of intra-op bronchospasm, I guess the first thing to do is to deepen the anesthetic. That's what most people would recommend. You can use inhalation agent or propofol. And then opiates and lidocaine as an adjunct for intubation are very commonly used to achieve an adequate anesthetic depth. Give oxygen to breathe. Albuterol is the quickest agent that we have available to treat bronchospasm. And in severe cases, intravenous epinephrine is probably the most potent breaker of bronchospasm, causes pretty much immediate bronchial dilatation and stimulates bronchial beta receptors. If you don't have an IV yet, in the pediatric world, we have on occasion given sub-Q epinephrine or epinephrine down an airway that you just try to place without an IV in place if you have severe bronchospasm. And it's not the code dose. I would start out with a tenth of a code dose and then work your way from there. It's very effective too. And you can do that in adults too. It's easily forgotten, but you can do IM epi to break bronchospasm. Intravenous corticosteroids, again, not so much for immediate treatment, but for prevention of recurrence when you're in that situation is advisable. The inhalational anesthetics that we have, isoflurane as well as sevoflurane, have bronchodilating effects in patients with COPD, so that's great. Desflurane, on the other hand, and we don't have that much available anymore, but we used to, due to the pungency of the airway, is probably not as good for these patients. The capnogram that is depicted here is actually shown pretty nicely, that when you have a severe COPD and you do an expiratory pause, you have very slowly appearing CO2 in the exhaled limb. So it just shows you how long it can sometimes take for these patients to actually exhale. The characteristic picture of the expiratory and tidal CO2 is the shark fin appearance of a bronchospastic or obstructed airway. That's depicted on the left in green. So the ventilation strategy for these patients is to try to avoid air trapping. Intrinsic PEEP is a big problem. reduce your respiratory rate, allow for more time to exhale, since they need more time to even exhale their CO2, decrease the I/E ratio, and if you have to allow permissive hypercapnia, it's usually well tolerated. Most of these patients have increased CO2 as baseline, and pressure control ventilation may be a better choice because of the rapid deceleration of the inspiratory flow at the end of inspiration. So there's the less time spent on inspiration and pressure control overall. And use extrinsic PEEP very cautiously. Always think about the intrinsic PEEP that these patients may build up on top of what you dial in. The dynamic hyperinflation, here shown in this graph, that occurs when mechanical ventilation cycles before, oops, oh my goodness. That occurs before the patient has really exhaled, has basically the effect that over time, this would be a normal expiration, but this is the prolonged expiration of a COPD, that over time, with each breath that is not quite completed to exhalation, you get air trapping. And that can be significant to the point that you have a hard time A, ventilating, and B, with hemodynamics. Once your intrathoracic pressures get so high that they impede venous return to the right heart, you may have hemodynamic collapse just because of ventilation strategy. That's not easily recognized. Basically what they're showing here is that this patient, when they stopped and did an expiratory pause, it took a long time for this end-tidal CO2 to kind of reach the actual value and become flat. And instead of the 49 that you could see with previous ventilation, not being aware that you were not exhaling all the way, you now see the true end-tidal of 85 just by waiting. So if you are not so sure, an expiratory pause until you reach actually a flat and not this up curve. And here in the end-tidal, once you reach a flat one, is probably your more reliable actual measure. For post-operative management, you can use peri-extubation, a bronchodilator. Nothing wrong with using albuterol before extubation. You can extubate deeply anesthetized. You just have to be sure that you are able to mask these patients. But if they have a good airway, I personally extubate most these patients deep, rather than wait for them to cough and wake up, and then just wake up on the mask. Post-op pain control is an issue. Multimodal therapy has been kind of the trend of the day, either Neuraxia or regional blocks combined with non-narcotic analgesics. And the new one right now, very helpful in these patients around extubation time too, is dexmedetomidine. You've all seen that very nicely. It doesn't suppress any airway or any respiratory effort. And Toradol, you can use that as well. Humidify the inhaled gases. We don't have humidifiers in our anesthesia machines, but it has shown to be helpful. If you want that, you can only get that on an ICU ventilator, not on our machines though. And extubation to CPAP or BiPAP is sometimes not a bad idea, to just go directly extubate, go to a CPAP or BiPAP machine. Respiratory therapy will come to the OR and set that up for you if you want to extubate right to that, so that you don't have to roll all along the hallway, get to PACU, some minutes pass by, the patient de-recruits, and may get into trouble that way. So in a severe COPD, it's worthwhile to have respiratory set up their BiPAP machine already. You extubate, you put the BiPAP on immediately, and roll with it out to PACU. So it's just something to remember, that you can always call for that. They bring you everything you need. They'll bring you a vent, everything. Restrictive pulmonary disease, on the other hand, not as common. There's several restrictive types out there. There's the intrinsic restrictive pulmonary disease, with comprised probably mostly of pulmonary edema. It's the most common we see. Can be acute respiratory distress syndrome, ARDS, pneumonia, aspiration or radiation pneumonitis, and sarcoidosis. The extrinsic restrictive diseases are more neuromuscular disorders, scoliosis, pneumothorax or pleural effusions, or obesity. For restrictive pulmonary diseases, the problem are decreased lung volumes, including the FRC, so quite the opposite of obstructive, decreased compliance, normal resistance though, and preserved expiratory flow, and for these patients, rapid shallow breathing is actually more effective. So the flow volume lobe for restrictive disease is on the opposite spectrum here. It's shown right here. Overall smaller volumes, overall lung volume smaller, everything smaller. But there's no obstruction to expiratory flow here. So we have a decreased FVC, decreased FEV1, but a normal FEV1 over FVC ratio, and decreased in, you can have a decreased diffusion capacity for CO2. The characteristic or classic picture of restrictive pulmonary disease is fine dry crackles on the chest x-ray shown here, not hyperinflation, but this fine ground glass appearance. The actual lung tissue is kind of affected everywhere pretty equally. On ABG, you can see a hypoxemia if it's come to a later stage, but usually these patients are normocarbic, unlike the obstructors. And the vital capacity is often under 15 milliliter per kilo, and that's pretty severe restrictive disease. Normal vital capacity is 70 ml per kilo. Okay. Ventilation strategy for these patients, smaller volumes, higher rate, may be beneficial. There has been this ARDS network trial in 2000, which everybody has been citing for the last 10 years. Because we don't have any other successes in ARDS. That was the study that showed that low tidal volumes of 6 to 8 ml per kilo plus permissive hypercapnia, they allowed up to down to a pH of 7.15, were the only shown treatment with benefit in ARDS patients, actual survival benefit. And that has now been applied to other restrictive diseases as well. So, well, I created this on a Mac, so it is A, B, C, but it's showing us all A here today. A is the answer. So I have these little questions here at the end, and I have a little cheat sheet towards the very end. Which of the following statements regarding lung compliance is false? If you look through there. Probably hard to read even through all of that, but these are questions that you may come across in exams. Well, we'll see. Answer is A for now, right? Okay. In which of the following situations is work of breathing most efficient with slow, deep breaths? That's an easy one. The last one, right? COPD. FRC, what is FRC? Yeah. It's all A here today. Which of the following tests is most useful and cost-effective in screening overall lung function? It's probably overall spirometry, right? The cost-effectiveness especially. The others are not. More expensive and more difficult to do. Maximum benefit from preoperative smoking cessation, of course, at approximately 8 weeks, exactly. But after 24 hours, carboxyhemoglobin goes down, so that's important to know. Which of the following statements regarding smoking and lung disease is false? And I know that's a lot of text. But we have some A, B, C, D, and E here. see. I have the cheat sheet at the end. All of the following strategies reduce the risk of postoperative pulmonary complications, except really what has never been shown is that any particular anesthetic technique reduces it. Okay, so it would be actually A in this one. Pain management, spirometry, early ambulation, and CPAP have all shown to be beneficial. But which technique you use, there's not a ruling out there. Which of the following statements is true? Sudden decrease in personal entitle and a mechanical. No, PE is not that often. Preoperative pulmonary function testing more important to predict the likelihood? Not really, right? We said it's not recommended anymore as a routine preoperatively, only for for planning of lung resection. So patients having intrathoracic operations are slightly lower risk. Patients having abdominal surgery, and that's true. So upper abdominal is the worst. Patients with COPD had increased risk for developing auto-PEEP while intubated. Which of the following strategies does not prevent the development of auto-PEEP? That's an easy one. So the first three are advisable, right? You reduce your tidal volume in the COPD, you allow a little bit hypercapnia, and that's fine. You prolong the expiratory phase since expiration is prolonged naturally in these patients, but if you limit your inspired O2 concentration, that doesn't really do anything to auto-PEEP or no. Right? Pulmonary dead space increases with? What is dead space? What do we call dead space? Correct. Yeah, yeah. So PE, you don't perfuse, but you still ventilate, right? Which of the following are usually effective treatments for postoperative hypoxemia? Spirometry. Yeah. Intermittent positive pressure breathing techniques. Sounds pretty good. CPAP. Endotracheal intubation. Continuous CPAP PEEP. Okay. Any good guesses? Honestly, I don't even know anymore. Which patient has obstructive versus restrictive pulmonary disease? Patient A, this here, compared to normal, that's restrictive, right? And then classic obstruction. So we had that right. Oh, I had two options in 11. Trick question, and I didn't even remember, so. Usually effective A and C. Oh, this sounded good too, though. But, okay, get this for a question, but. So this will all be recorded online if you want to look over the questions just for future testing. And I'm happy to entertain questions now or later if you come up with anything. I'm always happy to also find more literature if you would like to. Yeah.
The intra-abdominal surgery has a higher rate of pulmonary complications than intrathoracic.
Yeah. Yeah, I think so. I was surprised by that too. That's why I put it in here. Which question was that? Let me make sure. 8, right? C, yeah. And I can't yeah, it does. It did seem counterintuitive to me too. And I can't really explain that because you would think that if they go into the thorax, that you would have more postoperative pulmonary complications as well. But statistically, it's the other way. So upper abdominal, and maybe it's more. I don't know. I can't really explain it. But I thought that was interesting enough to throw it out here. Mm-hmm. I don't know of any studies. No, I personally don't do that, and I don't know of any studies who would show that it works. It takes a long time for that lidocaine to actually get through. It would have to diffuse through the cuff, right, into the sort of pericuff area to then anesthetize the mucosa around the cuff. So that may happen if you have a 10, 12-hour surgery, I think. I doubted that would be useful in shorter cases than that. What I think is very helpful, though, is using lidocaine kind of around the tube and through the tube, peri-extubation or peri-intubation, to use an LTA at the beginning and at the end. Now that would hit right the mucosal areas, right? I think that would make more sense to me. You could even let the cuff down and spray a little bit around the tube, let it run through, and give a little bit through the tube as well. To me, that would make more sense. Yeah, that's the thick 5% that we have out there. Mm-hmm. Mm-hmm. Now, I'm not sure about the formulation of that. I thought that may be a little bit of it's not very liquidy. It's pretty thick, and I'm personally a little worried in introducing that thick carrier of the lidocaine into the lower airways. Now, we use that for nasal trumpets a lot, but it is the highest concentration lidocaine we have. Yes, it'll work. I just don't know. I would have to really look at what the surrounding carrier is, whether you can introduce that into the lower airways as well without any trouble. Because I would worry that it gets even harder later. I'm not sure about that. But the lidocaine jelly that we have, that's clearly liquidy and made for that, is not as high of a concentration. I think is that also 2% at most? Yeah. It's 4%. I don't know. I think it's just 2. Yeah. Thank you.